Thank you very much and welcome everybody to our WHPA webinar. It's entitled Tackling AMR in a Changing World, What's Next After the UN High-Level Meeting. And I have the pleasure today moderating. We originally had Dr. Catherine Duggan on the next slide, who is the CEO and also the chair of WHPA. She was supposed to be the moderator today, but unfortunately she cannot be here today, but she asked me to moderate instead. My name is Zuzana Kusinova. I am the lead for policy, practice and compliance at FIP, and I'm also part of the WHPA policy and advocacy team, leading policy issues for healthcare professionals around the globe. So welcome everyone, and thank you for those joining us live and also those listening in afterwards. I would also like to warmly welcome our guests, whom I will shortly introduce. I have the particular pleasure of moderating this webinar today, and the WHPA brings together the global organizations representing the world's dentists, nurses, pharmacists, physicians, and physiotherapists. And in total, we speak for more than 41 million healthcare professionals in more than 130 countries. Our overall aim is to improve global health and the quality of patient care. And key to achieving this aim is our role in facilitating collaboration among the healthcare professionals as major stakeholders, and also collaboration with WHO, World Health Organization, while presenting a united voice of healthcare professionals globally. We were founded in 1999, so we just had our 25th anniversary this year, and we celebrated with the side event at the World Health Assembly in Geneva in Switzerland, where we launched our new strategy. This strategy sets out 3 priority blocks. First is building a sustainable health workforce. Second is strengthening health systems. And the third one is championing collaborative practice. We work towards these goals this year. For example, we have advocacy work at WHO top governance level and at the UN Summit for the Future. And also we issued an open letter calling for the protection of all health professionals in conflict. And today we will talk about AMR. It has been a long concern for us. We developed the first fact sheet on this topic in 2011, and we are also holding social media campaigns. For example, last year, you can see some examples on the slide. And we are also kicking off the World Antimicrobial Awareness Week for this year. You can see the campaign logo on the top right side of the slide. And I would like to encourage you to participate in this campaign. AMR, as you know, has a particular relevance currently. And also the world's leaders recently gathered at the UN in New York to hold the high-level meeting on AMR, which we will talk about, because some of our presenters were there in person, so we have the privilege to ask them about it. This meeting also with the 4th high-level ministerial conference on AMR that took place just a few days ago in Saudi Arabia marked increased political attention to AMR, which we are very happy to see. And we will be exploring today what effects does it all have, and also what kind of attention does it bring. We will be also looking at how global health inequities affect AMR strategies. We will talk about evolving public health messaging on AMR. And in closing, we will also hear from all the panelists on how they see the role of interprofessional collaboration in tackling AMR. So that's a lot to get through. So let's get started. But first, let me say a few announcements. Please note this event will be recorded. It is also live streamed on FIP YouTube profile, and the recording will be available at our website. To all those listening, please feel free to send your questions through the Q&A box or through the chat box, and we will be picking up those throughout the session. And I will just tell you a little bit about the format. Each speaker will give a brief 5-minute intervention on their topic, but we will also invite the other panelists to respond and react if needed. And we will also take questions from the audience throughout the webinar. So please feel free to put up your question the moment you have it, so that we can ask the speakers about it. And of course, at the end, there will be a dedicated Q&A for any remaining comments or concerns or questions. This event is translated to Turkish language. And we will have 3 speakers today. Dr. Kalin Matar is Associate Professor of Medicine and Director at Global Health Education and Partnerships at Washington University at St. Louis, USA. She was nominated by the World Medical Association to be here with us. We also have Dr. Enrico Castro-Sanchez, who is the Senior Lecturer in Global Challenges, Planetary Health at Brunel University, UK. He was nominated by International Council of Nurses. And last but not least, we have Dr. Wendy Thompson with us. She is an academic dentist working at the Northwest of England. She was nominated by the FDI World Dental Federation. I will introduce them also with biographies with their impressive bios later in the program. But first, I would like to start with Kalin Matar. Let me tell you about her bio. Dr. Kalin Matar is Associate Professor of Medicine and Director of Global Health Education and Partnership at School of Medicine at Washington University at St. Louis, USA. Kalin is interested in AMR and the prevention of hospital-acquired infections in resource-limited settings. She collaborates with the World Health Organization, specifically on AMR, health workforce, and infection prevention and control. She is also interested in global health policy and governance. Kalin has previously served in leadership roles at international organizations such as the World Medical Association, where she was a policy expert on public health and infectious diseases. She teaches global health at the undergraduate level, as well as medical students, residents, and fellows. She is currently researching the implementation of AMR stewardship and infection prevention programs in resource-limited settings. In 2023, Kalin was named the first Global Health Education and Partnership Director at Washington University School of Medicine. Her responsibilities include overseeing global health education and building bilateral global partnerships. So very nice having you here, Kalin. We will ask you a few questions to start the discussion. So as my first question, Kalin, we have been talking about the UN high-level meeting. Can you please summarize some general outcomes of the UN high-level meeting, and were there high levels of political commitment? And also, if you can say whether is increased funding going to address the implementation gap? And if you could also tell us about the key financial and operational challenges to implementing effective AMR strategies, and how does the meeting contribute to resolving these? Thank you so much, Kalin. The floor is yours.
And thank you so much, Susanna, for the invitation. And it is fantastic to be here on the first day of World Antimicrobial Resistance Awareness Week with this really great group of colleagues from all over the world. I think this is fantastic to see the engagement of healthcare professionals from everywhere. And I'm going to tell you in a little bit why I believe that today and this webinar are particularly important. And I hope that we can all come together in the near future to address AMR challenges at the national, local, and global level. So maybe I will just start a little bit by briefly telling everyone about the process of a high-level meeting, because I know sometimes this global political discussions are very far from the realities that we all face at the front lines of caring for our communities and our patients. these days, about every year or few years, there is a big health issue that is elevated at the level of the UN in New York. So it's taken out of the World Health Assembly and WHO in Geneva and taken up one level higher, if you will, at the UN General Assembly. And what does that really mean? That means that we have heads of states, we have ministers from various sectors outside of health that are present there. So really a prime audience to discuss especially a cross-cutting issue like AMR. So in September of 2024, we had this high-level meeting on AMR, but this is not the first one. We had one in 2016 when the world was slowly waking up that AMR is an issue. And then we committed together through a declaration to come back in 2024 and look at what happened in these 8 years or so with regards to progress, and then make new commitments. So we ended up with a very long awaited, but also very long negotiations, a declaration that has 106 points and spans 15 pages, coming from the declaration of 2016 that was barely about 2 pages. So what does that really mean? I think that means that we've made some progress. We made quite a bit of progress. And what is in these 106 points? There are several commitments that member states came together to say that this is what we're going to try to do. I will say that the human health side is actually quite strong. And it is, as I mentioned, a cross-cutting issue. I think all of us know that. I don't probably need to tell you that. So the 4 different entities that were involved, so animal health, agriculture, environment, and human health, they've all strengthened their commitments, but I think the human health side is really very big. I will mention also that we as healthcare professionals have not only contributed, but have advocated with governments, with member states, with consultations that some of you may have attended throughout this past year for us to see what is really important from the frontline healthcare professionals, and not only specialists, because I think specialists are always very engaged. But what does it really mean? Every one of us here either will prescribe an antibiotic or will be caring for a patient who has an infection, will be responsible for dispensing antibiotics, etc. So all of us are very heavily involved, irrespective of our specific specialties. AMR touches each and every one of us. So after a long advocacy with different member states, there are actually a few of these commitments that are very relevant to the health workforce in general. I will mention 104, 29, 94, and this declaration is, by the way, fully available online. So I encourage you to take a quick look, not at the 15 pages. I don't think you're going to want to read all of that, but at least at some of the points that I mentioned, where there is a call for specific investment in human resources for health and health workforce, in the health workforce that is necessary to tackle AMR. And I think that is a very big step, because for the longest, we, the healthcare professionals, were seen as the recipient of education, that we're misbehaving and somebody else needs to tell us what to do. Whereas I think everybody here would agree that all of us know our day-to-day reality better than anyone else, and we understand the challenges. I would mention, for example, if we are in a resource-constrained setting and we don't have anything else to help a very sick patient but an antibiotic, no diagnostics, no possibilities for any procedures, etc. I think the data shows that we are inclined to do whatever we can, even if it is that single antibiotic, to try to help the sick individual and patient in front of us. And I think that's what we all signed up for as healthcare professionals when we decided to get into our practice and our job. So I think this is a part that is kind of often forgotten when it becomes a conversation of, oh, healthcare professionals need to prescribe antibiotics better, need to do infection prevention and control better. But what do we say when we don't have enough nurses, enough doctors, enough pharmacists, and everybody is completely overworked and burnt out? And so how do you tell these people that you have to spend 30 minutes counseling your patient that they don't need antibiotics, or you have to make sure that every single step of your infection prevention and control is done when 40 other patients are waiting for you. So those are very key points that we came together to bring forward to some of those member states, and we were heard. And I think that this is a very, very big step, because taking our advocacy from Geneva to New York is always a big challenge. In Geneva, we tend to be listened to a little bit more. In New York, it's a whole different ballgame, and I would think that this is a very big win. And this is one of those that Susanna alluded to in her question to me, is kind of how do we kind of take things? What does this mean? This really big declaration in New York, what is it going to mean for each one of us here on this call? And I think I'll elaborate on that further in a little bit. But I think the hope is always that after these big meetings in New York, that we end up with more investment. And investment usually starts with money, because we do need funds to be able to tackle each and every one of these commitments at every single level. And I would say particularly these national action plans. So every country was mandated a few years back to make a specific strategy that is relevant for them in a very standardized format, if you will, that is cross-cutting from all aspects. And many countries, actually most countries, over 90%, have made that national action plan. They haven't funded it because many countries don't have the necessary funds. And some of them are a little bit at the start of the implementation stage, but there are so many steps that are needed for that process to continue. And this is where we're hoping that there will be this commitment for funding at the national level will take place. I will also mention that there's a lot of hope for funding, be it on the research and development front for new diagnostics and antibiotics. But there is a mention of global solidarity, and this is a really big hope that it will help us take this funding to the places that need it the most, so that we don't always focus on the conversation of we need more antibiotics, we need more diagnostics. But every other step in between, which, as I mentioned, funding of those national action plans, supporting the education of healthcare professionals, retention, et cetera, and then all the other cross-cutting issues that span all the aspects of One Health. So this is where the hope is. Susanna also alluded to the high-level ministerial meeting in Jeddah, which is just concluded, where about a month and a half after that big New York meeting, there was another ministerial meeting that was convened to show that, yes, we are still committed, and we are very committed. But what I will mention, though, is that there were great discussions and repeated commitments, but we haven't seen any significant commitment by governments to say, we're going to put in money into AMR just yet. So we are still at a place where we're talking the talk, we're not walking the talk just yet. But it still is quite early, but we're very hopeful that there will be commitments that are more concrete, not just commitments on paper, that will help each and every country to take forward these national action plans. I will mention, and I think we can always come back to that in the discussion, that it's very crucial that these national action plans and the high-level meeting declaration specifically mentions healthcare workforce as a key stakeholder in the implementation and also the development of these national action plans. And I think that is an opportunity that all of us present here, all 387 of us, should take ownership and try to see how we can get involved at the national level on this development and implementation, so that nothing that is done about us or for us is done without us. And I think that's always a motto that the youth group brings forward, and I think that's fantastic. But I do believe that as a group of interprofessional health professionals, we really need to come together in order to make sure that whatever next steps come in decision making, in planning, policies in AMR are really taking into account the realities at the front line, which sometimes is one of the major challenges. I think I'm going to stop here and turn it back to Susanna. Thank you.
Thank you so much, Kalina, for this excellent answer. And also good to hear that the healthcare professionals are being heard, also at the global level. As you said, from Geneva to New York, we also see a lot of people tuning in from all over the world, from Geneva to New York, from all regions around the globe. So thank you everyone who is writing on the chat and who is listening. I would like to continue, or before we continue, I would like to just still ask quickly whether Enrique and Wendy want to comment on this. And if so, you can do that. Otherwise, I would go to introduce Enrique. Hello, Enrique. It's nice to see you. So Dr. Enrique Castro Sanchez is the senior lecturer in global health challenges at Planetary Health at Brunel University, UK. He gained his degree in nursing in Spain and migrated to the UK shortly after to practice in infectious diseases. He completed his PhD in 2015 and received postdoctoral funding to research participation of nurses in antimicrobial stewardship in South Africa and Rwanda, and social determinants of infections. In 2016, Enrique was elected as an emerging leader in international infectious diseases by the International Society for Infectious Diseases. In 2017, he worked as consultant for the World Health Organization, developing leadership education for national focal persons in infection control, supporting the core components in infection control. Later, he worked as Infection Prevention and Control Fellow in NHS England, developing education for board members and senior IPC nurses. Enrique has been funded to carry out research and provide education in multiple settings, including Pakistan, India, Rwanda, South Africa, Mexico, Chile, Argentina, and Spain. He's editor-in-chief of Infection Ecology and Epidemiological Journal and collaborates with the European Society of Specialist Organizations in Brussels. Very warm welcome, Enrique. And we have several questions for you. You will be talking about tackling AMR in the face of global health inequalities. So how does tackling AMR play out differently in low, middle, and high-income countries? And did the meetings that we just talked about acknowledge these differences and contribute to addressing global inequalities? Thank you so much. The floor is yours.
Thank you ever so much for the opportunity, and thank you to the ICN for thinking about me for this webinar. Colleen set up this scene really well for me, and I completely agree with her that it's so important that we transfer our expertise from the clinical setting to the policy making, policy shaping setting. And perhaps that's one of the gaps that we need to address. But I suppose it's really exciting for me, and it should be really exciting for us to see the continued political attention to AMR. And I was thinking about, from a planetary health perspective, how, just recently we've had several COP meetings trying to address and mitigate the impact of the climate crisis, the consequences and its determinants. And it's very interesting to see how drug-resistant infections are placed at the same level as the climate crisis in terms of the collaboration, particularly cross-sectoral collaboration and international collaboration. And that was one of the strongest themes coming from the high-level meeting on AMR. And some of the commitments from the JEDAC commitments also focus on governance and capacity building. So it's really exciting to see how AMR discussion is aligned well with other planetary health and planetary threats discussions. These reflections about the global health inequalities and how AMR is not just the output, the result of these inequalities, but also a powerful driver of inequalities should also be a reminder to all of us as healthcare professionals that we don't just have a clinical responsibility, we have got a much wider responsibility to address the determinants of these global health inequalities. And thinking about AMR, I think that for a while we've positioned the differences between high resource settings and low resource settings as that difference between excess of use in high resource settings and lack of access or lack of use in low resource settings. And that is true. We cannot forget that in many low resource settings around the world, the challenges of antimicrobial resistance are related to the lack of opportunities to use optimal therapies, the lack of opportunities to use diagnostics, and as well, the need to use antibiotics to respond to those structural inequalities in terms of living conditions and water, sanitation, the most essential and fundamental rights that we enjoy in high resource settings. So it is true that there are obvious differences. I suppose it would be wrong to forget that in many high resource settings, we also have got really large pockets of inequality and poverty and deprivation. And just recently, this or last week, we saw data in the UK in one of our national reports highlighting how there was a marked difference in infections experienced by those who were in the lowest socioeconomic position compared with other more privileged groups. So I wouldn't want anyone in the audience to forget that this debate about global health inequalities and AMR as a determinant and as a result of these inequalities is not just confined to low resource settings, and that's something that it should keep us humble, that these challenges remain. Exciting to see that AMR is talked about in this inequalities language, and it's fascinating to see how in the last 10 years we've moved from AMR as just a clinical issue or mainly a clinical issue to AMR as mainly a political issue, a mainly a rights issue. And you would have seen, or you may have seen, the fascinating work that's done by colleagues such as Dr. Smita Sharani in Liverpool and South Africa, highlighting the challenges and the plight of women and individuals from certain ethnic groups and certain societal positions in terms of access to antimicrobials and benefiting from them. So these global inequalities are not just economic inequalities, but also gender inequalities, also, ethnic inequalities. And again, we mustn't forget that if we are to address AMR appropriately, those are technical developments and technical improvements that we've seen, those calls for developing more and better antibiotics. Of course, they're right. Of course, we need to get those. Of course, the need to develop optimal diagnostics remains. And you wouldn't hear me not supporting and advocating for those developments, technical developments, research developments which must get to all those who need them. And again, we go back to those inequalities of access to diagnostics and so on. But as I was sort of like suggesting, we cannot just stop on the drugs and the healthcare workers and the diagnostics. We need to remind ourselves that the determinants of infections, the determinants of inappropriate or suboptimal use of antimicrobials are really the wider determinants of health and illness, the classic determinants of health and illness. And although we are healthcare professionals, we have to continue advocating for governments and policymakers to address those determinants, the wider determinants of health and illness, before we can feel satisfied that we will be on the right course to challenge, the threat of AMR. And of course, this opens opportunities for us healthcare workers, because it means that even if we're not working directly on AMS, we can be working on infection prevention and control. We can be working on water and sanitation. We can promote vaccination. So we have got plenty of opportunities. Even if you're not working on those areas, then you can choose to work on the wider determinants. But also those opportunities are coupled with challenges, because typically healthcare professionals, as Colleen has said, we're not trained, we're not used to health diplomacy, we're not used to this political engagement, and we probably don't have the skills yet to be effective operating at the scale within this context. So, you know, we have got those challenges, but also we have got those opportunities. And particular or personal criticism to these high-level meetings that we've seen is that they probably, in my opinion, personal opinion, they're focusing too much on the clinical, on the biological, on the bugs and drugs aspect of AMR, rather than widening the net as much as they could in terms of the sort of the wider public health, the wider social determinants. So that's perhaps something I would like to see much more. And that capacity building is should not just be focused on more and better education and training for healthcare professionals, but also what are we going to do to address that chronic shortage of healthcare professionals around the world. I suppose that's been a bit of a reflection about those inequalities, I hope.
Thank you so much, Enrique. You definitely covered it very well, and from very different points and various angles. So thank you very much for that. And indeed, the AMR is one of the indicators of the whole social determinants of health. And this brings me to the next speaker, Dr. Wendy Thompson. Welcome.
Thank you very much.
I will shortly introduce you. Dr. Wendy Thompson is an academic dentist working in the northwest of England. She's a clinical lecturer in primary dental care based at University of Manchester and works part-time as the general dentist practitioner at Dentist Clinic in Cumbria. Wendy is the lead author of the FDI, World Dental Federation's white paper on tackling antibiotic resistance and has been their lead educator for the new MOOC in collaboration with the British Society for Antimicrobial Chemotherapy. Wendy also delivers continuing professional development on dental antimicrobial prescribing, resistance and stewardship for dental and medical teams on behalf of Health Education England. She's also a co-chair of the Society for Academic Primary Care's dental subgroup. So thank you very much, Wendy, for being with us today. We again have a few questions for you. You will be talking about the evolving public health messaging to promote antimicrobial stewardship. So how should public health messaging evolve to promote AMR, both among healthcare professionals, but also among public? Thank you.
Thank you very much, Susanna. Thank you very much for inviting me to be part of this panel today. It's absolutely fascinating working with colleagues from across the professions, all in the same direction, all wanting to achieve the same end. The commitment within the United Nations high-level meeting on AMR's political declaration, for those of you interested in going and cross-referencing it, is Commitment 51. This is all about the communications. And it talks about a One Health approach. So although we are human healthcare professionals here, we need to remember as well that this is about vets, it's about environmental scientists, it's about agriculture, it's about farmers. And so I'm struck by a phrase called "the medium is the message." And what that means is that the form of the message determines how it will be perceived. And so I'm actually going to turn this around. You would usually be used to hearing about what messages we want to share and then how to do it. And I'm going to turn that around and talk about the medium first, how to do it, and talk about the messages. What I learned from the high-level meeting and its side meetings, and I think I probably already knew this, but I hadn't quite internalized it, is that people want to hear AMR messages from a person that they trust. They don't want to read it in a leaflet. They don't want to get to the end of an appointment and then someone thrust a leaflet in their hand and say, read that. They don't want to be directed to an online website to go and find out more information. The things that they want to hear and the way that they take on information is from someone that they trust. And people learn through stories as well. So the World Health Organization has started using patient and survivor stories much more in the way that it talks about AMR. And some of you will have heard Vanessa Carter. She is the chair of the World Health Organization's AMR survivor group. And as a dentist myself, she is particularly interesting because her MRSA infection was in her face. It was treated by a maxillofacial surgeon. They are both a dental and a medical professional. And it's really powerful to hear the impact that antimicrobial resistance actually has on people here and now. This isn't a future pandemic. It's here and it's happening. And I've just been looking at the Q&A questions going through, and again, one of them, in fact, a couple of them really struck a chord with me. So it was talking about, for me, it talked about the medium again. So if we're trying to tell people not to use antibiotics as much because they're really, really important and should be being protected, then what message are people taking from the medium of the pharmacy store man being allowed to sell antimicrobial drugs without a prescription? That's a message that's being delivered very strongly in some places of the world, that it's okay to take antibiotics without a prescription, and as they feel it's necessary. And we need to think carefully, not just about the words that we're using, but about the messages that people are receiving. And if I think again about these trusted professionals that people want to hear the messages from, we are healthcare professionals. So maybe if you've got a toothache, you might want to hear from me as a dentist about the procedure rather than the prescription is going to sort you out, and I can do the procedure for you. But in the One Health agenda, we also need to think about farmers and who they trust, and that will be veterinary surgeons, won't it? And they've been absolutely fantastic and strong in the kind of messaging that they're delivering. But of course, the farmers don't just look after the animals, they also look after their children, they look after their own health. If a farmer gets toothache, he might think about whether he might need an antibiotic. By the way, he doesn't, very rarely. And he might think about his cows. He might think about the farm garden, the kitchen garden that his wife grows maybe vegetables in, that she might use antifungals for out in the garden to protect the vegetables that she's growing. These are all antimicrobials being used in different ways. He might use Corcidil chlorhexidine mouthwash for rinsing his mouth out every morning after cleaning his teeth. Again, these are antimicrobials and having an impact on antimicrobial resistance. So what I'm saying is that when we're doing the public health messaging, we need to think about the messages being received by people from lots and lots of different directions, not just about the one message that we want to deliver. So I'm going to move over to the messages now. We've done the medium. And messages, the language that's used is really important. People can only learn using terminology that they understand. And there is increasing evidence within the literature, and I'm quite certain that you all are aware of this anyway from talking to your friends and your family about it. AMR, or antimicrobial resistance, is a concept that's really hard for people to understand. It's hard enough to say. When I heard a newsreader on the television stumbling over how to say it, I knew that there was a problem. We know that the public relate to antibiotic resistance much more easily than they relate to the term AMR, or antimicrobial resistance. But even then, not everybody understands what antibiotics are. In some languages, there isn't even a word for antibiotics. Analgesics and antibiotics are sometimes used interchangeably by people who just don't understand. So the messaging needs to be really, really carefully thought through and contextualized for what works. And within the high-level declaration, so the words within the high-level declaration were about promoting awareness of AMR and the appropriate use and disposal of antimicrobials. And I'm sure that means something very different in lots of different places. And we need to think about how we deliver that to the people that we work with, to our friends and family, and then growing that up into the big international organizations as well. But one term which has been being increasingly used is the silent pandemic. And some of you will have seen a paper by Mark Mendelsohn recently, in which he says we need to be really careful about using that terminology. Sure, it's a pandemic. It's absolutely a pandemic. More people are dying from antibiotic-resistant infections than HIV and malaria. But if we use the term silent, then it risks people hearing silence. We need to make sure that we're not being silenced as a group. So we need to talk about a pandemic, not a silent pandemic. The other thing that the high-level declaration talks about is the importance of social scientists, behaviour change. If we're going to deliver messages, we need to think carefully about how they're delivered. That's the medium that we've talked about. And also the words, the type of language that we used, which I've talked about with the terminology, and the way that those words are received. There is a lot of science behind all of this, and we need to be involving those social scientists who can really help with those behaviour changes. And we heard at the Fleming Initiative at the side meeting at the in the UN, one of the side meetings, the importance of behaviour change science that the Fleming Initiative is placing on it. So the bottom line really is that the messages need to match what people need and want to know. So the person, the audience for your messages, what they need and want to know, with what us as specialists want to tell them. And if there is a mismatch in what people need and want to know with what we want to tell them, then we end up not communicating very well. And what we really want to work out is what people want to hear, and then matching them with what we want them to hear, and then how to deliver that. For example, I want people to know that antibiotics don't cure toothache. You probably don't want to hear that. You probably want to know, so what does cure toothache? That's how we can work out the messages together. But if we just focus on one side or the other side, we end up not communicating, because communication is a two-way street. Public health messaging isn't just about sending out broadcasting messages, it's about engaging the community. And that's one of the areas, again, that this commitment number 51 from the political declaration talks about. And it finally talks again, I'll go back round full circle, it talks about the importance of engaging patients and families as partners. So it isn't about broadcasting messages, it's about engaging them on a level playing field. Thank you very much.
Thank you very much, Wendy, for telling us more about the public health messaging. And indeed, as you say, the trust is very important, to build the trust. And also healthcare professionals have very good relationships usually with their patients, and there is the trust that is being built. I also just wanted to react to something you said about the pharmacist. Well, we generally, as pharmacists, do not issue antibiotics without prescription. It's not the best practice. And also in FIP, we are aware and are issuing policy documents on the AMR that support appropriate use of antibiotics. But indeed, it is important, as you say, to target the public well and be also aware of what is happening on the ground. So thank you very much for your presentation.
Yeah, on that point, what you say there is very apt in high-income countries, but in very, very many countries, people can go to. The Q&A talks about a pharmacy storeman, which isn't necessarily a pharmacist.
That's true, that's correct,
drug
yes.
stores in very many places, and that's the point that they're making. So it wasn't a dig at pharmacists. This was talking about the reality in many, many low middle income countries.
Thank you so much, Wendy.
No worries.
Okay, so we have a couple of questions that is coming through the Q&A. What we can do next is to ask all of our speakers to be there. And maybe I would ask Colleen, who spoke first, but of course, everybody, please stay with us. Also, Wendy and Enrique, in case you need to comment on what Colleen will say. I want to ask you again about the HLM declaration. You did touch upon what it means for healthcare professionals, but can you maybe give us one concrete example how will this declaration translate into healthcare professionals at frontline? Thank you.
Thank you so much, Susanna. And I also noticed that there was a question that's a little bit along the same lines in the Q&A. So also about how does this translate into anything at the national level, especially in countries that have limited resources. And I think this is really key. I think there will be two different groups of countries. One that may be very enthusiastic about trying to implement whatever they can out of this declaration, and another group where they may wait for a little nudge. And I think this is where the role of healthcare professionals at any stage, including students, including early career professionals and associations, to really take a step forward. So those commitments also mandated reporting from countries. So not only you can certainly wait to see if those commitments are going to translate into projects, into finances, etc. And they may very well do that. But I think that all of us here coming together is a testimony that we all believe that AMR is an issue of a significant public health concern. We just heard about the numbers a little while ago from Susanna, from Wendy. So we really cannot wait. So from what can you do? As a group, we can go to our ministries of health. We can go to, there are AMR focal points in every country. Usually in the Ministry of Health, they can be in other places, and ask, what is it that you're doing to implement what you signed up for at the high-level meeting? And oftentimes there may be things that are being done, but they are just not communicated to you. And this is where we want to make sure that, as we discussed before, that we are included. You may see opportunities for education, for training. There may be opportunities that are coming not only from the national level, but more so from WHO regional offices, country offices, etc. So from that perspective, I also invite you to make sure that you are on the distribution list for these various methods of communications. Of course, I think each one of our health professional associations are doing their best to keep track of that and taking it to members, but also the WHO at various levels, both the regional as well as the headquarters in Geneva, do that quite well. So those would be, I think, concrete steps where you can also get involved. We can also keep your own government accountable, and then see it hopefully translate into gains for you at the front line. One last thing I want to mention on that front is that along with this big political commitments coming out of the HLM and the UN, there will be likely some funders that are coming from private entities that are also very excited about this momentum. Those vary by country and region, but there may be a lot of opportunities for kind of small scale local AMR programs, and those are going to be really coming up and gearing up, I would say, over the next year or so. So if that is of interest to you, this is another way to get engaged and translate some of those gains that may not be directly through the government, but also could mean something very concrete for you at the front line. And I think I'll stop here. Thank you so much, Kalina. And also you highlighted the advocacy, which is very important. So would Enrique or Wendy want to comment on this about advocacy? How can healthcare professionals engage? Kalina already gave us some tips. Enrique, would you like to?
I think that the comments up until now have been really, really powerful. And I was thinking, communication is a two-way thing in terms of advocacy as well. And many of the initiatives that there are already happening at grassroots level that you don't really get to know unless you go and meet the people. We need to encourage the communication and the learning from those initiatives and the impact they already have, to travel to those higher levels where decisions are made, and again the inequalities in production of science and knowledge, and how much it costs to publish And that's a luxury that many of our colleagues in many places around the world don't really have. So then their experiences are not transmitted to other settings. So that would be a way of empowering that advocacy. But I completely agree that we need to educate, advocate, and act. And that's another way of acting, or could be.
Enrique, I will stay with you a little bit longer. So you talked about health inequalities, and we have a question about how and where can healthcare professionals be most effective in addressing these? Thank you.
Thank you. Well, I suppose that we're not going to resolve health inequalities in the consultation rooms. And we as healthcare workers, we can deal with the consequences of these inequalities. But it's classic public health. We've been trained in that way, of the courses and traveling upstream. And it may be that we really need to decide at some point that in order to be extremely effective, we need to take our clinical hats and think about a bit more like political operators. It doesn't mean getting into politics, which is an option. But I think that we are powerful because we are experts. We are powerful because we are millions of healthcare workers. We can have an impact by putting our opinion there about the impact of certain policies, which of course are not going to be health policies, the ones driving these health inequalities. They're going to be employment policies, they're going to be labor policies, transport policies, housing policies. And I think that that's an area where healthcare workers need to really, really, really step up to the plate. On the other hand, we have got a bit of a challenge nowadays where being an expert doesn't really guarantee you the ear of the policy and decision maker. And, unfortunately, ebbs and flows in politics means that sometimes our job as advisors and experts to ministers and prime ministers and presidents could be a little bit more difficult. So that's another skill we need to practice and sharpen up, how to convince or influence decision makers.
Thank you so much, Enrique. Wendy, you were at the HLM as well in New York. What did you pick at the side meetings? Because we talked about the main meetings, but there were also side meetings. And also, if you can say if there was, what was the fanciest venue? That is also a question. Thank you.
The fanciest venue? Oh gosh, there were so many. I went to a Japanese, the Nippon Club. I went to the Danish consulate. I think that was probably the fanciest one. Sorry, Japan. The Danish embassy had an outdoor terrace that you could just look over. It was all at the sunset, so you could just look down. I can't remember which avenue it was, but it was maybe 3rd Avenue. I can't remember. But yeah, it was very good. And I was there supporting Vanessa Carter, who I've mentioned. She was the patient advocate because she had her survivor story to tell. I think my main thing, I've already shared with you some of the messages coming out through the medium, but for me, the medium being more important than the words was what was really key. And one of the things that since the at the high level meeting, actually, here's one of the real nuggets. There is a group of people, it's an informal group, and Colleen will know where I'm coming from, called Women for Women in AMR. And it has just grown organically because there aren't that many of us really out there, but the gender issues, which I think, was it Enrique talked about the gender issues within AMR and the importance of highlighting them. And it then, once you have your eye tuned in and you start noticing things, you start noticing that there are some panels which are just male-only panels with women in kind of a supporting role rather than actually a leadership role. We have some really strong women in AMR. We have Dame Sally Davies, we have Dame Emma Wormsley. They're in very important positions, but we need to make sure that people at the lower echelons of the AMR, future leaders, are also able to climb those ladders along with everybody else. So yeah, I think those were the golden nuggets for me. Thank you.
Thank you so much, Wendy. It's excellent that you also had the chance to see the different side events and also tell us about it. So thank you so much for that. Colleen, back to you. What do you think about, just thinking about this and next year, talking about the local and national level a bit more? How can healthcare professionals engage a bit more in the future, in the next year and this year? Thank you.
Absolutely. And I'll kind of stay on the same train. I think the advocacy is really key, but I also see some really great comments in the Q&A and in the chat. I think healthcare professionals have a really crucial role to be the trusted voice. And I think Enrique alluded to the fact that in the whole world, we have a changing political landscape, and there is likely going to be I will say alternative sources of facts, of advice to policymakers, but also people who are going to get the stage that may not really be, I'm not going to say the most qualified, but may not have the most scientific and evidence-based views on things. And this is where we really need to step up because the world is becoming more and more globalized. A lot of people, especially young people, seek their health information from social media, where we are seeing a really big growing movement of these pseudoscience folks. And I think AMR has been a tiny bit shielded from that so far, but there's really no guarantee that we're going to continue to be shielded. There is something that Enrique mentioned before. Vaccines are crucial in the fight against AMR, and vaccines are under attack. So as a healthcare professional associations and healthcare professionals, we really need to engage with the public, and we really need to continue being the trusted source for information. And I will also mention that there's been a growing sentiment that is anti-healthcare professionals everywhere, that where people are talking about natural cure to diseases, etc. And I'm by no means denying that there are evidence-based natural therapies that some healthcare systems are very well versed in, and not so much others. But here we're talking about people coming off the street and deciding that they know better how to cure cancer or how to cure infections, etc. So this is where we play a really big role. So associations, we are coming together this year. We came together last year for World Antimicrobial Resistance Awareness Week, but we really need to continue that messaging throughout the year so that we enable our own members to be the trusted sources of information. We also have a role to come together to produce the materials and that our members need, especially in parts of the world where maybe the expertise that exists just needs a step further, because we have local experts everywhere, but local experts are often overburdened and overworked. How can we as international global associations support them with the materials and with the tools that they need in order to organize their own campaigns, in being the public-facing voices and faces of AMR? I think that is one thing that we really need to also work towards over this upcoming year or two. The momentum exists. There may be additional resources we can all tap into. There may be additional resources that can be tapped into at the national level. And as I mentioned before, being the people who keep our decision-making folks in power, political leaders, ministers, etc., accountable to what they signed up for. I think that is another really, really important point to mention. So I think I'll go ahead and stop here.
Thank you very much, Colleen. That was very insightful, also reflecting on the future that is coming. I have a question. Enrique, you mentioned the education and competencies. Can you tell us more about that, and what would help healthcare professionals, also thinking about ICN's work, and also in terms of the health inequalities? If you can tell us something more about that. Thank you.
Thank you. I suppose that education has been one of our star areas in terms of AMR. We have really develop, large number of competencies and position statements related to education in AMR across different disciplines. We have got a lot of data as well about the many gaps around the world in undergraduate and postgraduate and professional and CPD education. So I think it's fair to say that we have done well in education in terms of identifying what we needed to do and developing lots of resources that we've done. There are perhaps a couple of areas where we need to continue progressing. One of them is that we're focusing a lot in developing technical knowledge. By that, I mean, for nurses, for example, to know what is antimicrobial resistant and to know about microbiology and pharmacology and therapeutics. That is really essential and important and needed, definitely. But I think that what we're realizing is that we need to design and decide what is it that we want healthcare professionals to do in terms of AMR. What is it that we want them to do when they are in front of a patient who may want to have a prescription for what they think it could be an infection. And we now know that just providing technical knowledge is not enough to perform effectively when you're a prescriber or when you're not a prescriber. And I think that current curricula are not really designed to equip healthcare professionals with the kind of behaviors which are necessary. They are well designed to give them knowledge, but we know that that's not enough. And the other area where I think that we really need to do much more is to generate the evidence about what is it that our healthcare professional trainees are learning on clinical placements. We have got a lot of knowledge about what we learn in the classrooms and, in the European Union. Up until very recently, well, in the European Union, you still have got the EU Commission directive shaping nursing education. For example, in the UK, that may change, but we've got 4,600 hours in the usual nursing degree, 2,300 in the classroom, and 2,300 on clinical placements. And we don't have any evidence. We don't really know what happens on those 2,300 hours. And that's where we're doing some studies to try to find out. So that social learning that we know happens for doctors when they're training, for nurses when they're training, for pharmacies, for all healthcare professionals. We don't really know what happens in that socialization of learning about AMR. So we really need to know much more about what is it that we are passing on to the next generation when we're working with them, rather than generating some more, modules that are really useful, but they may come too late, because by the time that students have been on a placement, they may be already embedded in our ways of thinking and doing about AMR. So I think that those are big gaps or current gaps that we need to address.
Wendy, you want to add on that?
Come in and, thank you. Enrique, I absolutely agree with you on that. We hear so often from students or young healthcare professionals after they've graduated that they change their approach because their supervisor said, "Yeah, we know what you learned at university. Yeah, but now this is the real world." And we're all nodding. We all recognise this. And I'd never heard it called social learning, but you're absolutely right. And it fits with the research studies out there which talk about why don't clinicians follow guidelines. And clinicians don't follow guidelines because there's a guideline, and what you learn at university sits at the heart of it. But then it's like an onion with lots of layers. We have a layer because we met someone else that we trusted and they told us a different thing. We then got a complaint from a patient and said, "Oh, I don't want that to happen again." So you've learned something again through that social learning, really. And then you end up doing what you do. And if someone wants you to change, you say, "But yes, I've worked like this for the last 40 years and it worked for me, and now you're asking me to do something different." And that's a risk to what I do because I know that this works. But we need to make sure that those people who've been in practice for 40 years don't then pass on their habits. And what I say to people is, the students that I'm teaching now, 25, we're talking about 25 years time, more people are going to die from infection than from cancer. Well, 25 years ago is the millennium. What were you doing in the millennium? I know exactly where I was and the party I was having that night. And in 25 years time, we're going to have more people dying from infection than from cancer. I mean, that's crazy. And so the people who we're training now are going to be mid-career in 25 years time. And the people who've been using antibiotics willy-nilly, they're going to be the ones they'll be retired. They'll be the ones wanting to make sure the antibiotics work for them when their health's failing them. So yeah, it's really, really important, this social learning. Thank you for that, Enrique. That's a message I've taken home today. Thank you.
Delighted to hear. And I mean, the friction points we have in clinical practice are not about the lack of knowledge of drugs and bugs, isn't it? It's about what to do and what to do when we're part of a team and when we're working with other teams from other disciplines. And I never trained with people from other disciplines. I trained as a nurse with other nurses and nursing students to do nursing things. And then you go into the real world, and everybody is not a nurse, and they do different things. They know different things. They've got different expectations, and that interprofessional learning, it's difficult. But perhaps we really need to start building our learning centers, universities, or whatever they're going to be, as a transdisciplinary and interprofessional, simply to understand how do we make decisions together about AMR and about any other treatments. But yeah, I think that's the gap. It's not what do we need to know, but what do we need to do together?
Absolutely, and there have already been some efforts in this area where the healthcare professionals were training together, or the students were training together, dentists with physicians together with pharmacists, and it was very beneficial. There are already some studies out on that. And also with the World Health Organization, together as the World Health Professions Alliance, we sat down multiple times in the past, Kalina remembers, and we also contributed to the competency framework and to the training toolkit that is out there, ready for grabs to be used at the universities. So those are very important points. And Wendy, hopefully we will see it sooner than in 25 years, that there will be some positive change. But yeah, let's see what future brings indeed. I have another question for Wendy now. You have talked about Vanessa Carter, who is chair of the WHO AMR survivor group. And we also know that you are the trustee of the AMR narrative, who is this patient survivor advocacy charity. So tell us a bit more about this work and why is it relevant for us? Thank you.
Yeah, so I touched on this when I was talking earlier, that people learn through stories. A lot of our cultural learning, our religious learnings comes from stories in books that have been shared down through the generations. And there's really good reason for that. It's because how we learn. The research in this area goes back to Xerox, photocopiers. They did some work in the 60s and the 70s, and they said, there's no point just giving a manual to the guy who you're trying to get to fix all of the Xerox printers or the photocopiers. You need to he learns far more in a day from going out with a Xerox experienced engineer than he learns from a book. And this is the stories, the number of times you will, maybe through social media groups or maybe in your own coffee room at work, but you share stories with each other about a patient, something that worked well. That's how we learn far more than just being given a dry text to read. And so Vanessa's leadership of the World Health Organization Survivor Group came around the same sort of time as she'd been having this idea for a charity, because there wasn't one that existed, to support people to tell their stories. Because industry organizations, research groups all want the patient perspective. And there are lots of patient support groups for diabetes, for lots of different conditions, because especially for the chronic conditions, because people are living with it. But AMR, actually, unfortunately, a lot of people don't survive AMR, and the people who are living with it are actually very often really quite ill. They're really managing. So to bring them together is quite difficult. But actually, social media has done us a favour, and the whole COVID pandemic, focusing on infections, and AMR is just another kind of infection, did us a favour. And so Vanessa set up a charity, and she has various trustees. So Matt Mendelsohn, who I mentioned before, was until very recently one of the trustees. I can't remember off the top of my head the other names, but there are lots of people who you kind of go, oh, I know them. Oh, I know them. If you are looking for patient stories, then the AMR narrative, just search www.theamrnarrative.org, has stories already online and can direct you towards people who can share their stories and get involved with helping you shape up your piece of work, design your messaging, think about different ways of delivering something. So she works very closely with bioMérieux, for example. The Fleming Initiative, when we were at the side meetings in New York, there were countless times where she was the person on the stage. There's Noor, who Colleen knows from Lebanon. I think she's from the Lebanon. And there is Anthony, who had a bit of a shoulder problem, went for an operation, ended up with an MRSA, ended up with an infection, a resistant infection in his shoulder, and many operations down the line. He's a young man, he's fit and well. Just to talk to him, you wouldn't know, but he won't shake your hand because he's worried about damaging his shoulder. And you don't think about the impact on that on somebody. Not being able to shake people's hands, it feels tiny. It feels like a little thing. But the impact of that on somebody's life is quite huge. So so the AMR narrative is there as a resource for people to use. But also, so one of the questions I often ask people when I'm lecturing is, how many people do you know who have had a resistant infection? Now, I lecture dentists and dental teams, but for you guys who are infectious diseases people, you probably ask that and they'd know loads of people because just from their professional life. But in my dental world, because dentists deal with well people, we don't deal with sick people. Sick people go to hospitals, well people come for a regular dental checkup. So I just see normal people, just like the members of the public, really. And I say to dental teams, how many people do you know who've had a resistant infection? And there might be one or two people occasionally who say that they have, but nobody really. And then I say to them, how many times are you given an antibiotic that hasn't worked? And there'll be lots of nods. So why do you think it didn't work? And there's this little light bulb suddenly comes on over people's heads because people aren't aware. They know that antibiotic resistance is a thing, it's in the world, it's somewhere, but it's not in their world. They don't really recognize it. It's not something that can impact on them and their friends and their family and their patients. And you start talking a little bit more and they start watching. And the number of times that people now come back to me and say, you made me think about that. And I realized that. And then they start reeling these things off. One of the things that we're doing in the UK at the moment, or they've just done actually, it's been happening over a number of years, is that if someone has a death certificate, when they die, they get a death certificate. And if they've had a positive test for a resistant infection in the month before they die, that goes on their death certificate. The reason being that so often people with resistant infections, when they die from them, they're actually dying from something else, maybe cancer or whatever, that goes down on the death certificate. Because it's easier from a healthcare professional to write cancer down there, because people go, oh, that's really, really sad. But do you know what? It's just one of those things. People do die from cancer. Whereas there's about 20% of people who die of cancer don't die of cancer. They die with cancer, but of a resistant infection. And if you start getting the resistant infections on death certificates, people start realizing that it's there. That the clinicians don't like putting it onto death certificates because when the person came into the hospital, they didn't have an infection, and when they went out of the hospital, when they went out in a coffin, they had a resistant infection. That's what they died of. And so the clinicians are worried that the families are then going to say, so what happened? Did you kill grandma with the infection? Yeah. So it's easier for them to put cancer down rather than the infection, but they're being made to put the infection down now. So if there was a positive resistance test in the month before they died, it goes on the death certificate. That then starts raising public awareness about antimicrobial resistance. And going back to what I was talking about before, that's the medium, that is the message that people are getting. You don't need to say, or you can say till you're blue in the face, 10 million people are going to die of antibiotic-resistant infections by 2050. It doesn't mean anything. The numbers are too big, the timescales are too far. But if you start saying, blimey, my mother-in-law died of a resistant infection, that kind of hits home a bit more. Okay, sorry, I've rambled.
Absolutely. Absolutely. No, that is very true. And we do need more of these examples to just illustrate how big the problem is indeed. So thank you for doing that. I have a couple of questions for all of you. We have excellent audience, very active. People are writing on the chat and also in the Q&A box. So thank you so much, our audience, for that as well. We would love to answer everything, but let's try to at least cover some of the questions and comments that came in. Can you, because we were talking about this interprofessional collaboration and we want to also highlight it a little bit more. We also had some comments from the audience about interprofessional collaboration. Can you give us, each of you, just a quick example of that from collaboration on AMR specifically? I will start with Colleen. Go first, Wendy. Yes.
Okay.
Wendy, Colleen, and then Enrique. Thank you.
So during COVID, I ended up talking at a conference right after my PhD. I was sharing the results of my PhD. And next on the agenda was a vet, a small animal vet. And she had done a PhD about the same sort of time, and her results almost mirrored my results, absolutely. And what we both showed, or what I showed in my research, was that the factors that influence dentists to prescribe antibiotics are similar in many respects to GPs, but there are some very significant differences. And so you can't just take interventions for GP and put them into dentistry, because dentistry is a surgical profession. It's a surgical profession delivered in the community. So surgeons in hospitals have all of the hospital organization stuff that goes with it. That means that the surgeons get dragged into antimicrobial stewardship. And GPs don't really do surgery in the same way. It's not a hands-on clinical surgical profession. So dentists are out there on their own with that way of working. The vets are the same. The vets are veterinary surgeons. And again, they charge the patients for the pleasure of giving the care, doing the surgery. And they usually need to be doing a surgical procedure rather than just giving an antibiotic. So, for example, we can lance an infection, we can lance an abscess in a way that, you can't get inside the lungs if someone's got a chest infection, or you can't get inside the bladder with a scalpel if someone's got a urinary tract infection. But you can do in the mouth, and with animals, you usually can do as well in the same sort of way. So what we showed was that there is across the One Health agenda, the human and the animal, dentistry and veterinary come very close to each other in small animal practice and the human dentistry. So we have applied for funding from joint funding to do some work in Southeast Asia. We are keeping our fingers crossed at the moment we should hear in the next couple of weeks about whether we've got that funding. But I thought that was quite a nice project to show you that you would think that it should be a dentists and GP joined up piece, but actually it's too difficult to do those two together. The factors are too different. So vets and dentists are much closer.
Thank you very much. Colleen?
Yes, thanks a lot, Susanna. And it's always tough to follow Wendy because she always brings in fantastic examples. I will talk a little bit about my own practice, and then also maybe a little bit about the efforts that we do at the global level together. So I'm an infectious disease academic physician, and in my hospital we have, so I'm part of two different groups, which is our handshake stewardship team, which is fully interprofessional. So we have an infectious disease stewardship physician, and we have two pharmacists, and often have students from various areas. And this is really what's extremely helpful, that we all bring in our collective expertise to talk to various teams around the hospital about their antibiotic prescribing practices. So our pharmacy colleagues are phenomenal at helping us with dosing, with recommendations, with these very deep conversations about pharmacokinetics, pharmacodynamics, and then professional teams that we encounter in the intensive care unit setting, etc. Each one of us can answer the specific question that comes at us with quite a bit of expertise, and then we collectively are supporting, and we have the data to show that we have tremendously decreased the usage of broad spectrum antibiotics at every level in our adult hospital. I will also mention that my collaborators in Ghana have started a similar model that is led by an infectious disease physician with clinical pharmacists who have now trained with us to become specialists in antimicrobial stewardship. And we recently added an AMR champion group, which has a very large number of nurses who are supporting us with the frontline infection prevention issues, but also switches, for example, from intravenous to PO antibiotics. And they've been a really tremendous resource to engage other nurses also in the process. I will mention that the AMR champions were completely volunteer, and they decided to take time out of their very busy day to support the stewardship initiative. And I will mention that sometimes we are asking healthcare professionals to take an extra step for AMR, while it's really not part of their job description. And we are seeing people kind of respond to the call. And it is really, really great to see that without convincing each healthcare professional. And I hope today's webinar is going to convince everyone in attendance, which is a very large number of people, that each healthcare professional has a really big role to play in AMR. Of course, depending on the context that they are in, but we all have a duty and we all have a really big role to play. At the global level, Susanna mentioned the contributions that we brought together as health professionals associations to this competency toolkit that WHO published on education for healthcare workers on AMR. We also have convened our big group around the issue. We're always working together on the advocacy platform of AMR, because I was mentioning how big of a win it was for us to work with member states, specifically the government of Norway, for the inclusion of healthcare professionals and investment in healthcare professionals and resourcing in the high-level meeting declaration. And that came together as part of a consultation where FIP, ICN, FDI have participated as well. So this interprofessional collaboration and work has to be done at every level. At the global stage, we are all really good friends and we're working very well together. We certainly hope to see this also taken up at the national, but also at the local and frontline level. Thank you.
Thank you so much, Colleen. And just before I go to Enrique, I would still ask you, because there have been quite a few comments from our students who are the next generation that will be coming out of universities soon. What is your key message to them? Because you were also very active at the youth engagement. Thank you. If you can just quickly tell us.
Yes. So I would like to maybe just mention two different things. The students and the youth have been very active and very vocal at telling the global health space and what they want and what they need. And that has translated into very active youth groups at every level, including the WHO Youth Council. But I would like to mention specifically the Youth Quadripartite Group on AMR, which is also a group that was convened by all four UN organizations that is very active. There is actually a WHO, it's a quadripartite, but WHO took the lead on that toolkit on youth engagement in AMR. It is publicly available and it's a very long toolkit, but has about everything you need to see how you can engage at both at the local and national level. I will locate it in a second and put it in the chat. So please do engage on that front. Also, those of you who are part of the student organizations, push the student organizations to get involved even further on AMR. It had been an effort that was there for quite some time. There used to be a youth conference on AMR every single year for WOW Week, but this has really dwindled down. So, we talked about how crucial, important, urgent AMR is, but having come from a youth background and part of the IFMSA before my time with WMA, that was a long time ago, but will not say how long. But I think it's really wrong for the professional associations to tell the youth groups what they should do. I think all of you know very well what you want to do and how you want to be engaged. It's just about giving you the tool and expertise. But I will volunteer each one of our organizations to also support the student and the youth groups in your advocacy as well. So please feel free to reach out. But lots of opportunities and lots of guidance as well. And as I promised, I will put it in the chat. Thank you.
Thank you so much, Colleen. This is very encouraging. And we have Enrique. Enrique, if you could answer the question about the example, and also perhaps because there is a lot of buzz again around AI and the new team member that the AI brings, if you can also elaborate on that for the future. And with that, I think we will close because we are getting close to the end, unless Colleen and Wendy want to also comment on that. Thank you so much.
Thank you. Well, I was going to suggest that health professionals need to collaborate with many other professions, like software developers and artists and all kinds of other disciplines. But we can leave that for another seminar. I'll give you a couple of quick examples of interprofessional collaborations focused on health that I've been part of recently, that they've been really, really enjoyable. And I've learned massive amount about what other people do. One of them was developing a virtual reality training package with colleagues from the European Society of Intensive Care Medicine. And it was fascinating to see how doctors and pharmacists and nurses working in intensive care medicine make decisions about these really complicated, these really uncertain cases that they have to handle in intensive care, facing things like sepsis and very acute infections. So it was fascinating to see not just the decisions, but developing learning that can be then sort of packaged in a virtual reality platform, so anyone around the world can use it and be put in the shoes of them having to make decisions. It's not the real thing, but it's very close to it, and that was really useful. And it suggests how we can teach and learn, profiting from new tools. The other experience, which was really, really exciting last year, was an Erasmus Plus funded project. Sadly, as working in the UK, we could support that, but we couldn't be part of it. But it was a project led by colleagues at the University of Malta. Dr. Ermira Tatari was the lead a person for the project, where we develop an intensive AMR course for nurses, physiotherapists, and dietitians or nutritionists. And the beauty of it wasn't just that students learned about AMR, but it was the community of practice that was created with the students from Estonia, Malta, Belgium, Italy, and how they sort of came together to learn about AMR and what they could do. So it wasn't just the technical knowledge again, but it was the people from many parts of the world coming together to be the future leaders of practice in a globalized world, but also towards a globalized, planetary issues. So those two things have been really cool for me, really. AI, well, I suppose no one has been trained to deal with this new colleague that increasingly we see in our hospitals and clinics, this colleague which makes decisions completely in an unemotional way. And that's going to be quite interesting to see how humans who are pretty emotional, particularly dealing with uncertainty, and AMR often is a result of the uncertainty we have to resolve in a clinical setting. So we see lots of decision support systems and platforms that are emerging and being used in AMR. But I think that we haven't really explored how the specialists who have been studying for so many years are going to accept or not these suggestions from these platforms. So yeah, again, that may be something cool for another webinar.
Thank you so much. Certainly, there has been a lot of information said by all of you. Thank you very much, Enrique, also for touching on the new topics like AI. Do you have any very last sentence that you would like to say? I think from my side, we just want to say that the World Antimicrobial Awareness Week is starting. So we hope that this can be helpful for everyone to commemorate. And if not, then Joanna, can I have the slides, please, for the last wrap up? Thank you very much. I would like to thank you very much for attending. I would like to sincerely thank all of our panelists for their insights and the presence. Thank you also to the FIP Digital Events team that was working behind the scenes for the seamless production of this webinar. Thanks to WHPA for coordinating this event. Thank you, Joanna, specifically. And also thank you to the WHPA member organizations for their contribution from the inception of the webinar, for nominating speakers and promoting today's webinar. It's been a true demonstration of interprofessional collaboration in action today. And thank you for attending, our excellent audience, for all the questions and all the engagement. Thank you so much. As we said many times, it's World Antimicrobial Awareness Week until 24 November. So take part in as many activities as possible, also on social media. We will be recording this episode, or we have been recording this episode, so we will make it available on our website, as well as on WHPA's YouTube channel. And if you would like to keep up to date with our work, please sign up for the newsletter. There is the QR code for you on the screen. And also, if you have any feedback for us, you can give it to us at webinars@fip.org so that we can continue to improve our digital event offerings. Thank you very much and good day to all of you. Thank you.